Dear ladies and gentlemen, it's wonderful to see that so many have joined this webinar. Very welcome to this international webinar, which is one of several provided in a series from the Quality of Life Working Group in Örnsköldsvik. This webinar focuses on the respiratory burden in esophageal atresia, what we miss, and how we can do better. My name is Michaela Dellenmark Blom, and I am the moderator of this webinar today. We have the great honor to have two prominent speakers from Denmark with us. Elizabeth Christiansen, who is a pediatric pulmonologist from Hans Christian Andersen's Children's Hospital in Odense, Denmark, and Marika Runne, who is a medical doctor and a PhD student from Rigshospitalet Copenhagen, and she focuses her research on respiratory morbidity. And together they will present on the respiratory burden and quality of life in esophageal atresia, and they will share their experiences about the Tralulala initiative. Importantly, we also have the opportunity to listen and learn from the parent and patient perspective. Today, Louise Corneliusen, who is a mother, and Viggo Vidriksen, who was born with esophageal atresia, will share their story and key messages around respiratory morbidity in esophageal atresia. After we have listened to all speakers, you in the audience will have opportunity to ask questions, and I will do my best to moderate an interesting discussion. And this webinar will end in 1 hour. So with that, I will leave the word to the first speaker, Marika.
Thank you, Michaela. Yes, I am Marika, and I just went back to the first slide here because I wanted to just tell you that with this title, The Respiratory Burden in Esophageal Atresia, which we're going to tell you about, we challenged ourselves with the subtitle, What We Miss and How We Can Do Better. And hopefully we also challenged you a bit. So in the end, we hope to get your point of view. But today we are going to focus on the lungs, as I try to picture here, the lungs behind the esophageal atresia. And we are representing the respiratory, children's respiratory departments in this. And today our agenda will be this, and I think that that Michaela just outlined it. First, I'm going to briefly go through what is the respiratory burden and does it affect the quality of life. Elizabeth will present you the Tralulala initiative, the study we have in Denmark, and I will get back to you with some preliminary findings from these studies. And in the end, we'll have a patient perspective. And time for your questions in the end. So let's get to it. All right. I guess being in this webinar, you are quite familiar with what esophageal atresia is. But it is that the stomach and the mouth does not meet in the esophagus. There are a proximal and distal part of the esophagus. And usually one of these parts, and usually the distal part, this one, have a connection to the trachea. And this is a factor of that they share the same embryological origin, which is why it is also affecting the trachea. So usually tracheomalacia is present, and it's very different from all the different studies you can find. But tracheomalacia with this soft cartilage, not the C-ring cartilage of the trachea, is present in up to 86 of everyone born with esophageal atresia. And we believe that this is a contributor to respiratory symptoms in esophageal atresia. The respiratory symptoms is recurrent infection, chronic cough, and reduced lung function. And these are the same as with tracheomalacia, which can be present alone, not together with esophageal atresia. And we see that in the respiratory departments as well. So we get to see these two together. Okay, so just going a little bit deeper into the respiratory burden, I have this figure which I have modified a little bit, but from the care recommendations from 2020. On the, as you see it, it's on the left side. We have the tracheomalacia having a cartilage and maybe also ciliary dysfunction in the airways, which provides an airway collapse, especially during respiration. This drives a retention of mucus in the airways, which give rise to bacterial colonization. And the rest will be bronchitis, pneumonia, and we have seen that bronchiectasis, which is widening and damage of the lungs, permanent damage of the lungs, is more in patients with esophageal atresia, but definitely in patients with tracheomalacia. So that is the respiratory burden alone from the tracheomalacia. But besides that, esophageal atresia children and people in general with born with esophageal atresia, they also experience, some of them also experience vocal cord paralysis from the surgery they had correcting their esophageal atresia. They are very susceptible to tracheal compression from aorta and the thymus, which is in the mediastinum, pressing this soft trachea. And then if there is a food bolus, especially when there is an esophageal stricture remaining from the repair of esophageal atresia, this will also put pressure on the trachea, making it collapse, as you see here. Together with that, people with esophageal atresia also might experience swallowing difficulties, recurrent tracheoesophageal fistula, gastroesophageal reflux, regurgitation, and dysmotility of the esophagus. And all of this drives aspiration, which becomes a factor as well in the respiratory symptoms. In the end, there can be heart and vascular anomalies as well. So all of this together drives the symptoms that I put in the middle. I divided it into age group because the worst respiratory symptoms definitely exist while they are still small. So especially infants, the ones that are born with esophageal atresia, they can experience very drastic respiratory symptoms. They can have respiratory distress. They can have hypoxemic spells and stop breathing, apnea, but they definitely show a brassy or barking cough, and they also have some kind of stridor, evident that they have this soft trachea producing this sound. So persisting into to childhood and adolescence is the cough, and they say they also experience that there can be this barking laugh, or even a stridor, especially when doing exercise. They tell us that there is an exercise intolerance, and we see that they have impaired lung function. This is also present in adults. I can hear myself somewhere. Okay. And then, as I mentioned, there can be bronchiectasis. All right. This is a lot, and luckily it's not everyone that goes through all of these symptoms. There is a great variety of symptoms within the group of esophageal of children with esophageal atresia. So that's one thing to look at. Who is in favor of having the worst respiratory symptoms, who is in favor of the less, and who is not at all having these respiratory symptoms. We don't know for sure yet. But there is a great risk, I hope, that I've illustrated here. So the next thing is, how is this respiratory burden? How are these respiratory symptoms? How are they affecting these children? And what I show you here is that being part of the Quality of Life Working Group, we translated the Esophageal Atresia Quality of Life questionnaire into Danish. And we tested in this, what I show you here, 47 children born with esophageal atresia with these questionnaires. And we found, looking only at the respiratory symptoms and respiratory items, that respiratory symptoms significantly lowered health-related quality of life. And that's if they have stridor, dyspnea, airway infection, and chest tightness. Chest tightness only in the 2 to 7-year-olds. And if they have several respiratory symptoms, it was linked to a significantly lower health-related quality of life across all ages. So what we find here is that it's for every respiratory symptom that they say they have, their health-related quality of life score will drop 6 to 7 points. So that's quite, I think, a significant impact on the quality of life. And as we are in this area where I want to point out what are we missing, this is not completely new either. There have been several publications showing that respiratory symptoms, the respiratory burden in total, is affecting quality of life, especially in the group of 2 to 7-year-olds. In our new study here, we also show that it is present above 7 years old, and it is affecting their quality of life. So what are we actually missing? Sorry for this quite busy slide, but how should we look at this respiratory burden in the future? Well, in 2020, it was stated that that our literature was based on small single institution and retrospective series and case reports. So there would be a need for systematic reviews and randomized controlled trials to help better in the future. And since then, I found so this is, I guess, this is what we missed to actually have evidence-based guidelines to better the respiratory burden. And since 2020, I found that there is one prospective study from France where respiratory morbidity is accounting for over 50% of readmissions in the first year of life. So that's quite a thing. And I want to mention that there is right now an ongoing RCT, a randomized controlled trial, to see if the operation tracheopexia for the tracheomalacia, suggesting that tracheomalacia is playing a part in these respiratory symptoms. This group wants to see if an operation can relieve some of this respiratory burden. Because we know that we know the respiratory burden has been present for a long time. We know that it is affecting quality of life, but I think we're missing what we could do about it. What is the perfect follow-up? And maybe we have a way to figure that out. I will leave the mic for Elizabeth on this note.
Thank you very much, Marika. Do you want to change the slide for me, please? Yes, thank you. My name is Elizabeth Christensen, and I'm a pediatric pulmonologist from Odense, Denmark, and I will thank Annika for this opportunity to share our research. What I will talk a little bit about is the Tralulala initiative. We initiated the Danish Tralulala study, a national effort designed to systematically describe and understand the respiratory burden in children and adolescents born with esophageal atresia, and by that identify a targeted strategy to reduce this burden. So we asked ourselves, how can we do better? We hope that we, with this study, could identify what is need of respiratory follow-up for these children, what is the right lung function test, and maybe also identify the lung infections. Should we try to prevent them, or should we treat them more aggressively? Would you change slide? The trilular initiative stands for Trachea, Lung, Malaysia, Life, Adolescence. So we wanted to look at lung damage, lung functions, and quality of life in these children and adolescents. The initiative was launched in 2022 by Professor Kim G. Nielsen from the Rigshospital in Copenhagen, and he asked me to participate because we in Odense operate patients born with esophageal atresia from the western part of Denmark. Professor Nielsen has long been interested in launching a project that focused on the respiratory symptoms in these patients. He had observed that respiratory symptom frequency persist from childhood into adulthood. As we will see later on, the respiratory symptoms for some patients may be more pronounced than the eating problems that we have been focused a lot on in these patients. So our goal was, would you change the slide, please? Our goal was to improve our understanding of lung disease following esophageal atresia, identify the most accurate lung function test in this group. We have been thinking that normally we use the classical spirometry evaluating the lung functions in these tests, but we have been thinking that it might not be the right way to do it because of the dynamic collapse of the trachea during the forced expiration. So we wanted to investigate, is there any other kinds of lung function tests that would be more suitable for these patients? We also wanted to find out what the severity of the trachea was, and is it actually related to the respiratory symptom and clinical outcomes? What about the respiratory infection? What is the frequency? What is the clinical impact of these during childhood? And also in that way, maybe point out some ways to intervene to maybe reduce the burden of these respiratory symptoms. Would you change the slide? Yes. So we wanted to approach the respiratory burden in these children born with esophageal atresia in different ways. And we designed a study with different work packages, as you see here, with different goals. Firstly, in the work package 1, we wanted to create an overview how many children are born with esophageal atresia in Denmark over a 20 years period, and evaluate the respiratory morbidity. And that we did with a register study. And I will tell you a little about the results a little bit later, and it was published in 2026. In the work package 2, we used the quality of life questionnaire developed in Arnica to evaluate the burden of having a child born with esophageal atresia, as Marika just said. And we reported our findings to the Arnica Quality of Life group to enhance the power of our findings. As we had mentioned before, we hypothesized that the conventional spirometry might not be the best tool to evaluate the lung function in these children due to the dynamic collapse in the trachea in the forced expiration. Therefore, we created a pilot study to evaluate different methods to evaluate lung function. And from the findings in this pilot, we wanted to select those methods that would be the most suitable and use them in the work package 4, which was just started in the spring 2025. It's a cross-sectional national study where we invite all the children in Denmark born with esophageal atresia to evaluate structural interview, clinical examination, lung function, quality of life, CT, in some patients, CT scan, bronchoscopy, and also in some children blood test, which we will store in a biobank. So we, in the future, might look at genetic markers or other interesting markers in these children. The finding from the VP2 to 4 will form the foundation for future national cohort study, where we will create a national follow-up program for these patients, and in that way establish a national steering committee of dedicated people with different medical fields and also patients' representatives to drive the research forward. Would you change that? So the result from the publication for the work package 1 was published in Pediatric Pulmonology in 2026, and I will show you some of the results. We conducted a national population cohort study from 1998 to 2018 using the national patient registry. And we created a case control analysis using the prescription registry comparing lung disease management in children with esophageal atresia and compare it with age-matched children with asthma and healthy controls. We found that the incidence of esophageal atresia in Denmark was 2.5 per 10,000 live births, and it was stable in a 20 years period. And this number is pretty much matching what they are finding in other countries. In the first figure, as you see here in the top, we looked at the number of admittance to the hospital in patients born with esophageal atresia, which is the blue line, compared to children with asthma, the red line, and healthy controls, the green line. And as you see, there was a high number of hospital contacts in the first 3 years of life, probably related to the need of repeated esophageal dilatation, but it might also be due to respiratory tract infection, as Marika was pointing out a little bit earlier. Below, we looked at the use of antibiotic in these different kinds of groups, and we see here there was a high use of antibiotic in the group born with esophageal atresia, and this use was high all through childhood. And this could be the reason why we found this could be reflect the presence of the trachomalacia and other structural area abnormalities, as Marika said. We also evaluate the prescription of beta-2 agonist and inhaled corticosteroid and compared it with children born with asthma and healthy control, and this is also present here. The first one is the beta-2 agonist, where we see that children born with esophageal atresia, the blue line, had more prescription of beta-2 agonist than children with the asthma diagnosis, the red line. And below that, we also saw that the prescription of inhaled corticosteroids was higher in children born with esophageal atresia compared with children with the asthma diagnosis. And it might be due to the misinterpretation of the barking cause of asthma. So this was a key point of this publication. Would you change slide? Yeah. If you want to know a little bit more of the about the Cholula initiative, we have this website that you can visit. Thank you. And now I will give the word to Marika again.
Thank you, Elizabeth. Then I will pick it up from here with the preliminary findings from the work package 3 study, our pilot study, where, as Elizabeth told you, we hypothesized that standard spirometry using forced expiration will induce airway collapse and might hinder the interpretation of that lung function. So our aim with the pilot study was to characterize respiratory impairment using multiple lung function methods, as many as we could find, and identify the most appropriate test for children with tracheomalacia across all ages. So that's quite a name. Let's see how it went. I will present you with the poster presentations that we have had on the European Respiratory Society Congress and one Danish one as well. I will start with telling you about our first lung function. It's the multiple breath washout. The multiple breath washout is a tidal breathing test, which is why we thought this might be a relevant test here, since it is not inducing the dynamic collapse when tracheomalacia is present. Multiple breath washout is a test where the children, and it can be done all the way from infancy to adulthood, but they will have either a face mask or a mouthpiece to breathe into, and then they will breathe tidal breathing slowly, and we will change the air they are breathing from atmospheric air to 100% oxygen, and then we'll see as the test goes on when and how many times they will breathe until the air in the lungs is changed from atmospheric air to oxygen. This test will say something about ventilation inhomogeneity, which will be present if there is, for example, scarring or mucus plugging in especially the distal airways. This test is very well known from cystic fibrosis, where it is very good at detecting even small airway disease. So we did this on like 40 children, and we saw that it was elevated in quite some of the patients, especially in the infants 0 to 3 years of age. 90% had an elevated LCI score, as we say it, and an elevation in this case is not a good thing. So actually a lot of the infants had an elevated LCI score. For preschoolers 3 to 6 years, it was not as many, 70%, but it persisted into school-age children from 6 to 17 years of age, with almost 40% still having some kind of ventilation inhomogeneity. And as I cannot tell you what this exactly means, but we can say that it was definitely feasible to do this test, and it definitely tells us that there is something going on in the lungs of these children, because it is giving us some signals. So we are taking this test, tidal breathing test, further into our cross-sectional study in evaluating the lungs of this. And especially it will be nice for us to see if the infants having very high scores on this test will keep scoring this high, or it will normalize on the way. We also tested some other lung function, and in this one, I am arguing does pulmonary function in children and adolescents with esophageal atresia and tracheomalacia, does testing make sense? So this is the question that you've been hearing about a lot now. We are doing conventional spirometry with forced expiration. And in this figure down here, you will see that expiration in a patient with tracheomalacia, which we believe is present in a lot of patients with esophageal atresia, will induce quite a narrow airway, and we think that this will affect their regular spirometry. So in this one, we tried also with a slow vital capacity, which means it is not forced breathing, but we are still measuring lung volumes, but just at a slower rate, to see if there was any differences. And we also used the impulse oscillometry, which is a tidal breathing test measuring airway reactance using sound and air waves. So I will just briefly sum up that a lot of our patients were abnormal on the spirometry, especially the forced expiratory flow for 1 second and the mid-expiratory flow as well. So there is some kind of flow limitation. in the spirometry as we hypothesized. And with the slow vital capacity, measuring kind of the same things, but at a slower rate, there were no significant difference really. But using our impulse oscillometry in tidal breathing, they were not significantly different from healthy controls. So this supports kind of what we want to tell, that the spirometry might not reflect lung disease. An abnormal spirometry might not reflect lung disease. It might reflect the trachea collapsing on the way. If you follow me just to the last figure here, I have put in abnormal spirometry scores, and I have put in all scores from the spirometry and from the impulse oscillometry. And in this big blue, the big blue square is all the abnormal abnormal test from spirometry, but in the small rectangular one here is only 2 being abnormal in the impulse oscillometry. So I'm just suggesting from these findings that spirometry might not be where we find abnormal lungs, but maybe reflecting the tracheomalacia instead. And the last thing we looked at in the pilot study was that there is this exercise intolerance reported from these children and adults as well. So we put 18 of our children from 7 to 18 years old through cardiopulmonary testing to see if we could find what they are experiencing. And as I mentioned just before, a lot of them had a reduced spirometry. So in this case, it's half of the patients going through cardiopulmonary testing had an abnormal spirometry before the test. They had all normal diffusion capacities. And I will tell you that they also had now normal values with the reference material present for the cardiopulmonary testing. So in this, we could not find what they are subjectively saying, this exercise intolerance, in the cardiopulmonary testing. But we did find some abnormal breathing patterns that we will look further into. And we will also try to see this test together with healthy Danish children, as we are uncertain whether the reference material on children in cardiopulmonary testing is good for this one. So that is a lot of information and a lot of results, but I will sum up that we have, with a pilot study, of course, almost opened more questions that we have closed down, but I hope that I described for you, or I pictured it for you, that it is hard to interpret lung function in children with esophageal atresia and maybe also the tracheomalacia, and that we will have to look further into how they are showing on a longitudinal base, the multiple breath washout, the impulse oscillometry, and we will look further into which test of exercise capacity will be the best. And with that, I will leave the word to Mother Louise Corneliusen, who will tell us a bit about their respiratory journey, and her son, Viggo. And we are very thankful that they are here to tell their story today. We don't have a Danish patient group yet, but these have been very, very good at provoking the thoughts in our professor, making this study possible. So thank you, Louise. You can take the word from here.
Thank you so much, and thank you for wanting to hear our story. First of all, my name is Louise. I'm the mother of Viggo, and for a profession, I work as an anesthetic nurse at neurosurgery at Rigshospitalet in Copenhagen. Viggo is born with Vactal, and he has 5 out of the 7 malformations. But in this study, the only focus is on the tracheomalacia, of course. So, but the rest could be added too. Yeah, we have together with Marika decided to divide it into 4 groups, so we could separate the different stages of his age. And the respiratory journey started when Viggo was born and until the age of about 3, which we have called the first tough years. It was characterized by several respiratory collapse with cardiac arrest, also at home, the most of the time at home, where I have to revive him myself. And then he was, after that, he was admitted to pediatric surgery unit and intensive care unit for about 2.5 years ongoing without being out of the hospital. And in that period of time, he had also frequent surgery in that period also. After Viggo was 3, we have divided into 3 to 6 years old. He was still at home. He was not in together with other children yet because of the infection risk. But on guarding that, we have chose to call it the first improvements. He was in fixed treatment with antibiotics every day, a small amount for 2-3 years. But even though he was on that, he continued to have many infections, and he still needed hospitalization several times every year. But at the age of 5, he started in a forest kindergarten, but he still had like several sick days every month. But it helped him a lot that he was outside and not in smaller groups inside with a lot of children. And he was there for about 2 years before he started school at the age of 7. And we've called from 7 to 13, which was the next period where he had this gradual improvement. He started school and he joined a football team where he was not the fastest, but he could still run. And now in that period of time, he only had antibiotics when he was sick, when he had pneumonia or signs of it. And that was about 6 to 8, maybe 10 times a year still. But there was a turning point at about 12 years old, I think, where he starts running. And he actually runs his first half marathon when he was 14. And then he continues to play football and continuously runs like 2-3 times a week. And then there is today, from the age of 13 until now, every year he was improved better and better. But I think it's about when he was 18, I discovered myself that he has an ASD as a part of the Vactal syndrome, or not syndrome, but the Vactal. And after that was closed, he was experiencing some nausea, he couldn't walk straight and he was dizzy. And after that was closed, he could start running again and he starts exercising, and also that characteristic sea lion cough, he also got rid of that at the age of 17, I think. And about 15-16 years old, he was not repeatedly sick. He was no longer more sick than the rest of the family, maybe 1 time a year, 2 times a year. And now, within the last year. He has started running again, more and more, and is going to run the half marathon again this spring. But like we say, in the last picture should demonstrate that he can run, but he never leaves the country or go traveling without Citromax in his in his sandbag. So it's very seldom that he needs it, but he still needs it sometimes. But when we look back, we have never thought that this would be how he was today. It was difficult to see when he was at the small age, because of course all the hospitalization and all the medicine he was given and all these other comparing diseases that he has also has not helped with his lungs situation. So but there it is, how he is today. He still sleeps with his head high, both because of reflux, but also because of you tell me that you breathe easier when you sleep with your head high. So that he has always been doing that. Actually, I don't know about this study, but just previous to this, I started to talk about to Kim G. Nielsen, the professor at Rigshospitalet, about that spirometry that he has been doing often from the age of 5 until 11, 12 years old. And I was kind of wondering, because sometimes he could came like say in January, it has just been winter, and then he do the spirometry and it says like lung capacity of 90%. And then he has a couple of months where he maybe has been a little bit sick, but not much. And then he comes back, and 3 months later he could like do the spirometry again, and then his lung capacity was like 50. And then I, as a parent, I of course I worried about if his lungs continuously would worsen in that hurry, because then I could see the full picture that he would either die or had to have new lungs within the end of the year. But then I saw like a pattern that there was no pattern. He could like blow like 90%, and then 2 months later 60, and then 75 and 80 and 25, and then I talked to Kim that if he had those kissing walls in his trachea because of his tracheomalacia, then it would be like a lucky punch in boxing if he could like do 90%. And if it was on a bad day, it would be like 50. So I started talking to Viggo about, because he had that age where he was starting to get concerned about what is my future, and is it okay for me to still running, and is it possible for me to run when I do like 50% in my lung capacity? How is that possible? And we talked about that his lung capacity, it was not a clear picture that would reflect how his lung was doing. It was more than something about his trachea and how that was still soft, and because he was not that high yet, or he was still a little bit skinny, and maybe that was why he still had those kissing walls. So therefore, as a parent, you can experience that the choice of examination does not always reflect the reality. So that was our concern and our curiosity about why do you do like you do with those tests. And for like important, I think like important key points for you as professional, it could be try to limit worries and and be clear in your choice of words. And if you can separate esophageal problems from trachea and or lung problems, to see them as two different things, and recognize that the respiratory problems can be long term, even though the literature may say otherwise. The literature we were provided back then says that improvement of the age of 2 to 3 years old, they could start kindergarten and they could start to school, and there would be no more infection. But that was far from our reality, and there was no other parents that I could reflect or compare ourselves with. There was no one to talk to. So we just have to find our own path and make our own books. Yeah, I don't know if Marie.
Thank you so much, Louise. Yeah, thank you so much for this. Do you have anything more to add?
No, not until some questions maybe, or yeah.
And as I understand it, you are both ready for questions if there is anything.
Of course.
Good. Well, thank you, I will say to you, and thank you to all of you for listening. I will pass on the word back to Michaela.
Well, I also want to express my gratitude. Thank you, Louise and Viggo, for sharing your important experiences. And also thank you, Marika and Elizabeth, not only for a fantastic presentation, but also for your tremendous work that you're doing on helping out with respiratory morbidity in this population. With that, I'd like to open up to any comments and questions from the participants listening to this webinar. You can use the chat and you can raise hand. I see Anke, and I will let Anke speak.
Yeah, thank you very much. First of all, thank you for this touching report. My name is Anke. I'm president of the Esophageal Atresia Global Support Group Federation. So if you want to found a group in Denmark, please get in touch. But my interesting point would be now, what is our learning curve from this? So we know that some patients do have prolonged severe problems with their lung. Then it is getting better, but we know from our adults, if you don't care, and if you don't look, you might not see the point. So it's a bit like Louise already said, if we don't have data, we shouldn't promise something. So I think we should keep tracking very closely our patients and try to find solutions to prevent early possible complications later. And maybe to add, Louise, my son is 27. We had a little bit similar journey, although I think you had even with Viggo a few more points to challenge. And I'm with you. Feel hugged.
Thank you. Thank you.
Then I give the word to Una.
Mm-hmm.
Thank you so much. That was a fantastic talk. I'm Una McFadden. I'm a retired paediatrician and looked after a number of babies with esophageal atresia and tracheoesophageal fistula, and was involved in some research at that time on the breathing patterns of the babies that confirms exactly what you've been describing regarding the signs of tracheomalacia. And I've always wondered why we don't follow through on the the change in the tracheal dynamics as the child gets older, and thinking in adolescence how the tracheal cartilage becomes much stronger, and whether there is an opportunity to look at what interventions might be helpful at the different age stages. It was fascinating to hear the story of the young man who became so fit running half marathons. and whether we should be looking at trying CPAP to hold the trachea open, or PEP masks that we use with cystic fibrosis to help lung clearance during infection. But I don't know if these things are being researched now, because I have now retired, so I'm learning from you. But I think there's a lot of opportunity to look at crossover research using what has been learned from other types of respiratory disease, and assessing the possible implications of that for intervention. Thank you.
Elizabeth?
I think Louise also would like to answer that question, but I just wanted to point out that it's a very interesting that Una said about this CPAP evaluation, but we haven't seen that. We have some children that have high flow in home, which is not a research, but some of them might have might benefit of having high flow at home too. You know, the flow is opening up the trachea, but it's not anything we have looked at in research right now, but it's very interesting. And then I will also say thank you very much for Louise and Viggo to participate. And it's very interesting story, and I would like to ask you also, maybe sometimes it would be better that we don't do all these lung functions as well, maybe not the spirometry, because it was actually frustrating for you to hear this 50 or now 80 and so on.
Mm-hmm.
Any further questions? So I can see that we have some questions in the chat, and one that is repeated is around the question, what can we do better to prevent or mitigate symptoms associated with tracheomalacia after esophageal atresia repair? What would you say, Elizabeth and Marika?
Yes, thank you very much for that interesting question. I think Louise also wanted to comment on that, but now I can just answer the question. Well, we don't know what is the right way to do it, but what we wanted to look at is maybe could we prevent these respiratory infection during early childhood, maybe to adulthood, as Viggo was treating with prophylactic antibiotics. Might it be a good way to prevent this? And we will probably have a study starting up with looking at that. Another way to look at it, with, as Marika said, is should we operate for this? Should we do this orthopexia, or which children should we do that? Because as Louise said, Viggo has a lot of symptoms, but we also have other children that luckily are not that affected as Viggo has been. So there are different kinds of a perspective, but I think right now it's difficult to say what is the right way to go.
And Louise, you wanted to continue, please?
Yeah.
As well?
I just want to say that to add that when Viggo was around 2.5, 3, when I told you that he was getting those antibiotics, a small amount every day. If he's also born with not anal atresia, but Hirschsprung disease, and have almost the whole colon removed. And because of that, he cannot tolerate antibiotics that well. He gets colonized with Clostridium every time when he was smaller. And if he didn't have that disease, they would have given him antibiotics in a little larger amount. And therefore, their thoughts were that he would have been lesser, no, not that much sick that he still was until the age of 7. but because of his bone, he couldn't have that much antibiotics. But I think if he could have the full doses, he would have been even better. And actually, just to comment on those study of how their cartilage would maybe be harder or he would grow out of it. Viggo was together with Marika in a study when he was like 18, where he was doing this on this bike, where you saw how his trachea still collapsed, like in totally, still kissing walls as when he was little. But of course, it must have been better because he's doing much better now. But what the causes are, we don't really know, because he still have those collapse.
Anke, you wanted to say
Yeah,
something?
first of all, thank you, Louise. What you discovered, the collapse remains even when they are adult. I can confirm this. I mean, if you have a meeting of all those adults, you hear it, so you don't even need some sort of pictures to do. You simply hear it when they are coughing. I want to point on Gianluca and his two, as an adult pulmonologist, I think we have two fields where we have to proceed now. First of all, with all the knowledge we have now, thanks to your study and thanks to others, we have to start protecting the lungs. I mean, in Viggo's case, it was obviously very difficult, but this is not so rare either, because we do have a lot of Vactal patients who really suffer when they have to take antibiotics. So let's seek for other solutions, and the surgical one could be one. It's not up to me, but we have to look into it. And the second question, I really would inspire you to look into the older children who needs a special care once they get adult. Because if you don't look for bronchiectasis, you don't diagnose them, and then you don't treat them. And what we know is if the child has already bronchiectasis very early, there we might, please correct me when I'm wrong, you might get still opportunities to solve the problem. Once they are adult, they are there. You just can keep them under control, but you don't get rid of them anymore. And I think those are the two topics. And concerning the asthma diagnosis, yes, that's the most common diagnosis. Adult patients get in touch with us as patient support group. And until today, I met none who really had an asthma. They all had just a diagnosis.
Thank you, Anke. I can see that Marika and Louise also wanted to comment. So let's, this needs to be the last comments of this webinar, sadly, because this is such an important topic. I'm sure we could continue 1 more hour. Marika, you first, and then Louise.
Oh, there are so many things I can say. Thank you for these inspiring comments, both from Una. Let's be inspired from other diseases using, for example, prophylactic antibiotics as in PCD. And I really think you are very correct, Anke, in the way that we need to protect the lungs, not to evaluate bronchiectasis, but I would love to know, when does these bronchiectasis happen, and can we catch them before only developing, but also we should know before letting them out into adulthood. So that's a big question for me as well. How are the adults doing in Denmark? I don't know. So we are looking into that. Might look into that as well. So just thank you.
Thank you. And then we'll let Louise.
It was almost the same as Marika. I was also interested, of course, in how I could help Viggo in the future and how he can help himself. So we would like to be part of those groups in the future as well. Both me and Viggo, he can do the physical tests and I would do the talking. But also just to be in contact with other people, professional or private, or anyone who could, so we that we also could help some with the younger children who wants to see how you can do when you're 24 and 27 for you, Anke. And yeah, so thank you very much for letting us be a part of this.
Thank you. I think this inspires almost to one more webinar. We are not quite done yet, right?
No.
This is such an important topic. So we have more to present and more to discuss. But for today, we need to end this webinar, and I thank you all for contributing and for listening and joining this webinar.